In the morning. Okay, go ahead and get started. I'm guessing other people will roll in. I don't know if other folks ran into this, but traffic was horrible because sometimes people forget how to drive when it's raining. So it took me longer than usual to get here. I know a couple people have emailed and said they're going to be late because of traffic as well. So I wanted to take just a minute to check in with our syllabus, just so we can keep on top of what's coming up. So today and on Friday, we're going to keep working through motivation and emotion. We have a couple different assignments. I think one of them will come up today, one on Friday. And so Monday, what we're going to do is I will pass out the exam and we'll do a little review for it. And then you'll have until the start of class on Wednesday to complete it. And so that exam is take home, open book, open note, just not open print. So that way you all have plenty of time to get it done. But I wanted to kind of remind you of that, just in case you have anything big coming up, so that you can kind of schedule around that. If there's going to be some reason why you won't be able to be here on Monday to pick it up in person, please let me know. So we can make other arrangements. But for folks on Zoom, you will need to come get it in person. It is paper copy. So that's that. It is a combination of like multiple choice, true, false, and fill in the blank and short answer to give you the most opportunity. I know different people do well on different kinds of questions. So I wanted to make sure that it's not just one thing. Alrighty, well, with that being said, I want to dive on in to our motivation and emotion lecture here. So if you remember on Monday, we had been talking about societal pressures, right? And one of the things that we do in psychology when we realize there are a lot of societal pressures for something is we try really hard to figure out essentially what can we do to help alleviate some of those pressures? How can we help, basically? And in particular, this study I'm going to talk about thought about how can we help kids not to feel these pressures. And so they did this really interesting study. They had elementary school kids and they had pictures of celebrities. So I think it was like, at that point, it was like Jennifer Lopez and Britney Spears, folks like that. And they showed these pictures, girls to girls, boys to boys, and they said, what would you have to do to look like this? And the boys were really jokey. They were like, oh, you'd have to lift a house. You know, they like fully acknowledged this is not something that's normal or easy to do. But the girls reacted really seriously. And these are elementary school kids, so 1st through 5th grade. And they said things like, you'd have to not eat, or you'd have to eat and then throw up. So that was really sobering. And a couple of these co-authors were students at the time, and they worked with a fellow student who was an art major, and they developed this book called Shapesville. It's a cute little kid's book. It's about how having different body shapes just allows you to be able to do different things, essentially. And this book is now used in like comprehensive prevention programs against eating disorders and body image disturbance. So really cool initiatives you can get out of this. And so we have been mentioning eating disorders, but I haven't really like explained what those are. So wanted to go into those in a little more detail here. So these are among the most common problems in young females in particular, girls and women around y'all's age, in Western countries. So what do I mean when I say Western countries? I mean the US, Canada, Western Europe, Australia, essentially. And the prevalence rates don't look like they're awful, right? Like 0.5% of the population or 2 to 3% of the population. We do know that for the quote unquote like classical eating disorders, about 90% of the people who actually come in for treatment are girls or women. We know, however, that when you look at like people who don't come in for treatment but meet criteria for the disorder, there are more men. So somewhere in the order of 20 to 25% of patients are men. About 10 to 15% of girls and young women who are tested in studies actually score above the cutoff for probable disordered eating. They've also now developed questionnaires that you can use to essentially diagnose an eating disorder in a study. When I have used those, I have found really different numbers, which we'll see on the next slide. And about 1/3 of adolescent females will use some extreme form of weight control. So 33% will use something like purging, which means throwing up after you eat, or will use something like diet pills, which, just like side note about diet pills typically fall under what are called supplements. Supplements are not regulated by any body. So like, you know, when you take medication that's prescribed by your doctor or even like Tylenol, that has to go through FDA approval. Supplements don't. And so not all, but some supplements have really weird fillers in them. Some supplements, the active ingredient is so small that's like, why are you spending your money on this? And for diet pills in particular, they usually include a very powerful stimulant. So it's kind of like taking meth. And so when I was in grad school, there was this ad for a diet pill that was like more weight loss, faster weight loss, energy to burn. And it's like, yeah, because you're taking like cocaine, kind of, right? And then the other problem is you build up tolerance really, really quickly. And so then you have to take more and more of them. So these are things that I think are sort of normalized in our society to some extent, but maybe shouldn't be. I had a friend in undergrad who took some unregulated diet pills and ended up in a coma. She's a very extreme case, right? But you just want to be really, really careful whenever you're buying something that's a supplement. So for college women, folks around y'all's age, up to 61% of college women engage in some sort of disturbed eating behavior. So again, that doesn't mean they would be full criteria for an eating disorder, but it might mean things like skipping meals on purpose, using diet pills, using like water pills or laxatives, throwing up after they eat, using excessive exercise, things along those lines. And more than 80% of college women experience body dissatisfaction. I said this statistic the other day that 99% of women, and I believe it was like 93% of men, said that they would change something about their bodies if they could. So we've created this environment, right, where it is like acceptable and normalized to hate your body. And it has some dire consequences. So I mentioned I find slightly different numbers myself. So when I was at Kent State doing my graduate work, I did a study for my master's thesis where I found that 28.2% of that sample met criteria for an eating disorder. And then when I was working on my dissertation, I found that fully a third of that sample met criteria for an eating disorder. Now, does this mean that these are representative of numbers overall? Probably not, right? So we advertise these with like names of the studies and descriptions. So it's entirely possible that someone that was struggling with their eating might have been drawn to participate in this study, right? Because they're like, well, this is something this happening to me, so I'm interested in it. We also had some really interesting bias. So our psychology building was up on a hill, and we parked at the bottom of that hill. And at the bottom of that hill was the building for fashion design and fashion merchandise. So a lot of those folks would also take psych classes, participate in our sample pool. And unfortunately, there was a really high rate of eating disorders among those folks. We saw a lot of them in our clinic as well. So is this perfect representation? No, but that sure as heck is higher than 0.5 or 2 to 3%, right? So it's probably somewhere in the middle, and we're probably, when we look at these numbers that are reported, seeing an underrepresentation because a lot of people do not seek out therapy. And typically those numbers, when they say, oh, it's 2 to 3% of the population, are based on who comes in to get therapy. So this is just something to kind of keep in mind. Really interestingly, when I study it at BWU, I don't find that many people with eating disorders. This is actually a really good thing. I will roll with this. I love this. But it does mean that, like, if I ever wanted to just study people with eating disorders, I couldn't do it here. I will take that problem all day, every day, and not have folks here engaging in harmful behaviors on their bodies. As I mentioned, a lot of the patients are women. I think in the 3 years I saw eating disorder clients, 1, maybe 2 of my colleagues saw males with eating disorders. They're largely females who present for therapy, and there are more women than men who meet criteria for an eating disorder. And I already mentioned this about a third of folks using those weight control methods. So anorexia nervosa has to do with a fear of gaining weight. I'm realizing now that these are the criteria from the old DSM. So let me just edit this real quick. You don't have to have the absence of menstrual cycles anymore. A couple different reasons they took that criteria out. One is that sort of automatically excludes anyone who doesn't have a uterus from being diagnosed with it, right? And then the other reason is that a lot of women now are on birth control. And so they'll get something that looks like a period even when they're at very low body weight. And so this idea of like not maintaining ideal body weight, a fear of gaining weight. I think modern criteria also have some wording about essentially like not recognizing you're at low weight and still trying to lose weight. And then the cognitive distortions, and this picture here is a depiction of that they will look in the mirror and even though they're emaciated, see themselves as what we would see as like a normal weight. But to them, that's obese. They have very skewed perspectives of their own bodies and sometimes the bodies of other people. You can have both restricting and binge purge subtypes. Restricting is what we think of when we think of sort of like classical anorexia nervosa portrayed in movies. These are folks who eat very small amounts. Some of these folks will only eat 200, 400 calories per day. That's not enough to sustain your body, not shockingly. And then the binge purge is really interesting because we think of binge as just being a lot of calories. But for folks with this subtype of anorexia nervosa, it's actually can be what we call subjective binge. So for them, eating a whole sandwich might be a binge because typically, again, they're only eating like 200 calories per day. And so these subjective binges then cause them to perhaps purge, throw up, fast, use water pills or laxatives afterwards. So you have these restricted net intake of nourishment with that significantly low body weight, intense fear of gaining weight, even though they're underweight, or engaging in behavior that interferes with weight gain. One of the really interesting things I found recently in research is like, not everyone with anorexia nervosa can articulate that they're afraid of gaining weight, but they might still be engaging in these behaviors. And then those disordered perceptions, particularly related to their bodies, and then this undue influence of later shape on how they evaluate themselves. These could be people getting straight A's, and they often are, because they're often very perfectionistic. These could be people who are succeeding in many different areas of their lives, but then if one thing is wrong with their weight, they don't feel like they've lost enough, they don't feel like they're skinny enough, they think they're worthless. Or sometimes they're just denying the seriousness of their low weight. As you can imagine, this can lead to a whole host of physical issues. So cardiovascular complications. One of the main reasons I got really interested in studying eating disorders was when I was in college, I read an article, like a news article about a 22-year-old woman who was a ballet dancer who died of a heart attack. And it was because she had severe anorexia nervosa and her body essentially shut down. See, a lot of these folks do have cardiovascular issues, heart attack, strokes at very young ages, low blood pressure, sometimes their body temperature is unnaturally low as well. Their metabolism will slow way down. So your body wants to keep you alive, right? Like that's its job. And so your body will actually become as inefficient as possible at processing food to try to get the maximum amount of calories out of whatever little bit you're consuming. Fluid and electrolyte complications, this can come up for a whole host of reasons. If they have the binge purge subtype, throwing up can throw off your electrolytes. I had at least one client who was so thin that they could physically see when they drank water, like their stomach would distend a little bit. And so sometimes they will avoid drinking water for those reasons. Dental problems, again, particularly if they're binging, that brings up stomach acid, that can wear away at your teeth. But also if you're not getting enough nutrients, right? Teeth or bones, they can have issues because you're not adequately fueling your body. Just general gastrointestinal complications, dehydration. Lanugo is really interesting. So these are little downy hairs that grow on parts of your body that typically do not have hair. Babies are born with this, actually. My daughter was like, look, she has lanugo. And my husband was like, well, what are you talking about? But it's essentially your body trying to keep you warm. Because what happens when you're depriving yourself this much is your body will consume whatever it can, so it'll eat your fat reserves. And so then you don't have anything on your body to keep you warm. Your body will also eventually start eating your brain. So there are neurological studies showing that people with anorexia nervosa have decreased brain volume. Now the really good thing is when they recover, if they're able to recover, that brain volume comes back. Cessation of menstrual cycle, like I said, this used to be a symptom. It's not anymore simply because of the modern way we manage periods, but essentially your body prioritizes what it needs to give energy to, right? And if it needs to use all of its energy to just like keep you breathing and your heart beating, it's not going to bother like releasing an egg, right? It's not going to be like, oh, we could totally have a baby right now. And then there's possible permanent damage to bones in your reproductive system. Sometimes even teenagers with severe anorexia nervosa will develop osteoarthritis or osteoporosis. This is probably the most important part and often surprises folks, is that anorexia nervosa is the deadliest mental disorder. It's not depression, it's not schizophrenia, it's not PTSD. 10% of folks who are diagnosed with anorexia die as a result of this disease. Now, for some of them, it's literally, again, like that ballet dancer I read about. They might have their bodies just shut down on them. Some of them starve themselves to death slowly. Others of them will die by suicide as well. So this is the highest among any mental disorder. All right, so bulimia nervosa is, again, more common than anorexia nervosa. And you have both binges and purges. So binges are eating a large amount of food in a short amount of time with a feeling of a loss of control or like I can't stop. And I think I mentioned this when we were using this as an example and the research methods, but binges can be like all your calories for the day plus. Like some people will have like 2,000 calorie binges, some people will have 10,000 calorie binges. And then they'll engage in some sort of purging. So classically, a lot of people think like, oh, they just throw up. And I don't want to minimize the throwing up because it's really problematic for the body. But people do lots of different horrible things to their bodies to try to purge. So including using laxatives, if you're not familiar with laxatives, you're supposed to take them when you have constipation. But if you take them when you don't have constipation, it just flushes everything out the rear end, basically. Diuretics are water pills. They help you lose water weight. Fasting. So these folks will try to go all day without eating. For example, this is why intermittent fasting being like a trendy diet concerns people in the eating disorder field, because yeah, some people it's going to be totally fine, right? But if you have a propensity towards disordered eating, this could spark things for you, right? And then excessive exercise. So unfortunately, sometimes what happens within psychology is people study what they have. As for me, I mentioned like I got the spark of being interested in eating disorders based off reading this article. I luckily have never struggled with a diagnosable eating disorder, although certainly have experienced body dissatisfaction, as have most people. But there was a woman in our lab who had severe anorexia nervosa. My advisor eventually had to intervene. And one of our other lab mates lived in the same apartment complex as her, and he would leave at like 8 in the morning to come to school for the day, to campus for the day. And when he got back at like 3, he would see she's still in their workout room. Like she'd been there all day. So she's doing fine now. She has a very successful career. And as far as I know, has never had a relapse, right? But this can become really dangerous because imagine you're only eating 200, 400 calories a day, right? Or you haven't eaten all day because you're trying to avoid eating, and then you go and work out for like 2 8 hours, right? Lots of things are gonna happen, passing out, things like that. They also are gonna evaluate themselves based on their weight and shape. And you notice sort of very similar language between bulimia and anorexia here. This is why I study body dissatisfaction. It is a core feature of the eating disorders. It also, as I just mentioned, is a really common experience for folks. And so my goal is to help figure out how can we prevent it. People with bulimia nervosa, interestingly, are typically at quote unquote normal, whatever that is, right? or a little above normal weight. And that is partially because these methods of eliminating calories are not actually that effective. So for example, vomiting, I believe, maybe reduce you about half the calories that you've binged. Laxatives, diuretics, much less, right? And so these folks will just, not lose as much as they think they will. And then subtypes, there's a purging, and that would be people who do vomit. The non-purging would be people who do the fasting and the exercise, even though those are both sort of purging behaviors. And so here are the current criteria for bulimia nervosa. So recurrent episodes of that binge eating and recurrent inappropriate compensatory behavior in order to gain or prevent weight gain. And these have to happen at least once a week for 3 months. And some people just do this once a week. Some people do this several times a day. And then undue influence of weight or shape on self-evaluation. Okay, binge eating disorder was something that was in the appendix of the DSM-4, so from the 90s on. And there's this appendix back there that was basically, these are like categories that are probably disorders, but they need more research before we actually say they're a disorder. And it became a disorder in 2013 when the DSM-5 was printed. And so these folks essentially have all the features of bulimia nervosa without the purging. So they're having recurrent binges at least once a week for at least 6 months, lack of control during that binge episode, but not having those compensatory behaviors. So these folks are often overweight or obese. Does this mean every single person who's obese has binge eating disorder? No. And in fact, when I worked with the pre-bariatric surgery population, I would say maybe 10%, and that might be an overestimate, of our folks met criteria for this. It's not necessarily that common. And so one of the things I really liked that they did for the diagnosis of binge eating disorder was describing the binge in a lot more detail. And I hope that in the future, they'll use these same descriptors for the binge and bulimia nervosa. I just think it'd be really helpful. So they have to have 3 or more of the following: eating really fast, eating large amounts without physical hunger, eating until uncomfortably full, eating alone because of embarrassment, and feelings of self-disgust, depression, or severe guilt after these episodes. They've got distress about the binge eating, and as I mentioned, the same frequency as bulimia nervosa, and then no pattern of inappropriate compensatory behavior. There are other disorders that are sort of like things that we see but don't have their own diagnostic category. And these fall under other specified feeding and eating disorders, which they call OSFED. One of these is atypical anorexia. I have atypical in quotes because this is actually far more common than the anorexia nervosa I just described. So folks with atypical anorexia have all the symptoms of anorexia nervosa, but are not underweight. But they're engaging in eating very small amounts. They're engaging in, all of these other really detrimental behaviors. They'll have the same side effects. Like one of the side effects I didn't mention that can happen to people with anorexia nervosa, it's like their hair will just start falling out in chunks. That will happen to these folks. But because traditional anorexia nervosa was described with low weight, they've now decided to call this atypical, even though it's much more typical. So a lot of research is being done on this right now, and I would guess this will end up being its own diagnostic category whenever we get to DSM-6. Purging disorder is really interesting. So purging disorder is bulimia nervosa without the binges. So people who have purging disorder will purge essentially everything they eat, but never actually have binge eating episodes. So it's basically every time they eat, they go and they throw it up or they use laxatives or things along those lines. Again, really detrimental to your body. One of the things that can happen when you're vomiting this often is the stomach acid wears away at your dental enamel. So I had a client who had never had any cavities, and then the next time she went to the dentist after she began her bulimia, I want to say she had 3 or 4 all in one appointment. It can also cause problems to your esophagus. You can get ulcers in your esophagus from that stomach acid coming up. So not great. We'll also see people that, like, the term is sub-threshold. It's basically like they don't quite meet criteria for one of these other eating disorders, but it certainly is disturbing their life. So like maybe they are binging once every other week, right? But it's still really interfering with their life. So we would still give them like an OSFED diagnosis. Most insurances will cover that so that they could still get therapy. And I think with the revised criteria, it's a little better, but I know when I was in grad school under the DSM-4, something along the order of 60% of eating disorder cases fell under OSFED. So our criteria just weren't doing a really good job. A big part is that like binge eating disorder used to be under this. And so now that has its own, a lot of those have moved out. But this is something that's in general true. Like, what course is it? Geez, I think it's my capstone course. We're talking about personality disorders. And I think again, like 60% of personality disorders, the person meets criteria for like 2 or doesn't quite meet the criteria for any of them. We need to be better about our diagnostic categories, or fully acknowledge that these might not be categorical at all, but more on the spectrum. All right, so we've talked about motivation due to drives, right? We've talked about motivation due to societal pressures, but there are other types of motivation that people experience. So one of these is the need for achievement, as you see it, sometimes abbreviated NAC, I guess ASH, but this is your desire to attain a difficult but desired goal. So you all are using this type of motivation, right, to get you graduated. You know, just coming to class day after day, doing something that's, I know for some of you, may only be a year away, for some of you, it might be 4 years away. You already just being in this classroom have a baseline need for achievement that's higher than a lot of folks, right? Related to this is a sense of mastery. This is a focus on acquiring knowledge, but also developing skills. So you get satisfaction through mastering the material. This is the feeling you get when like you've struggled in, let's say, like your algebra class, and then all of a sudden it starts like clicking, and you're like, oh, this is how I do it, right? Or this is the feeling you get when you are doing some sort of experiential learning, maybe like an internship, and at first you feel like a little lost and intimidated, and then you realize, no, I got this, right? This is a feeling we're trying to help you all achieve. And then performance. For some folks, this is the bigger driver of the need for achievement. And this is essentially a competitive focus. This is the idea. I want to outperform everybody else in my class. I want to be top of the class on the first exam score, right? And there's nothing wrong with this at all, right? So this is another type of motivation. There's also sexual motivation, right? Humans are sexual creatures, as are most other primates. I remember one of my professors in undergrad telling us a story about when she was in grad school, they were assigned to go observe bonobo chimps at the zoo. If you don't know anything about bonobos, they are the most genetically similar to us. They share about 98% of our DNA. And bonobos are promiscuous, for lack of a better word. And she had not really thought about this. She just was like, oh, I'm going to the zoo, so I'm going to take my little niece with me. And they went in, and the bonobos were just wrestling the whole time, because bonobos will just have sex with everyone and everything in their troop. Doesn't matter the sex, gender, what have you. It's part of their social communication. And humans aren't quite the same, but certainly this is part of our social communication as well, right? So sexual cues are virtually any stimulus that becomes associated with genital touch and orgasm and sexual desire, can become a conditioned stimulus that motivates sexual activity, right? And for some folks, this is, I don't want to like yuck anybody's yum, but this is what was like socially acceptable, right? We think about wearing sexy clothes or doing certain things to like prepare yourself to feel sexy going out. For other people, this can be deviant in some ways, right? People with foot fetishes, things along those lines, right? Like somehow that got associated. And again, as long as it's not hurting anybody else, to each their own, right? Now, sexual scripts are socially learned ways of responding in sexual situations. Part of the problem that can happen, particularly when when people's parents or family are not very open in talking to them about sex, is that people are curious and they go and they learn from whatever sources they can find, right? And a lot of times in our modern world, this is porn. And so they'll get their only sexual scripts from porn. And those are often very unrealistic, right? And so that can learn to sexual frustration on the part of that person who learned that way, but also sometimes their partner, right? Both learning and genetics affect our sexual behaviors. We're still studying how genetics relates, but we know that they do. So this is certainly something that motivates people, right? Competing for mates. Some people will like act a fool trying to get other people's attention, right? Things along those lines. How do we study sexuality scientifically? Well, the first person who we really have documented doing this is Alfred Kinsey, who published 2 big books about this in 1948 and 1953. He interviewed 17,000 Americans concerning their sexual behavior. He had grad students that helped him do this, but he really wanted to know, like, why are people so interested in sex? What motivates people for sex? Things along those lines. And it really became obvious during Kinsey's work that many behaviors that were considered taboo at the time, or just, oh, that doesn't happen that commonly, were actually pretty widespread. So for example, he asked people about oral sex, and a lot of people were engaging in oral sex. And at that time, like, people didn't think that was true. The National Health and Social Life Survey happened in the 1990s, and they interviewed about 3,000 adults about sexual behavior. What they found is that there was an increase in the number of people who were sexually active at a younger age. So essentially the age at first intercourse was getting younger, and more young people were sexually active. People you may have heard of, because there was, I want to say, like an HBO or Showtime show about them a few years back, called Masters of Sex, is Masters and Johnson. And so they went beyond just interviewing people, and they actually observed sexual behavior in their lab. So they had people consenting, come in and engage in sexual behaviors and actually study it. So they directly observed and they recorded physiological patterns. So they would do things like look at respiration, heart rate. They actually were the first people to, like, I'm gonna say witness, but like see the interior of a female orgasm. They actually came up with a camera kind of attached to like a speculum-like thing so they could video that. So they actually were the first to really look at how are people reacting physically during sex. And they came up with this idea of the sexual response cycle. They said there's this 4-stage sequence that you go through. Now, I do have to say this has been somewhat disputed in recent years in terms of like not everybody goes through this in the same order. But they were the first ones to even talk about the idea of this. So like first you're aroused, you have desire, you're interested in sex. Then you reach something called plateau, where it's like you're still sexually excited, you're in this stage. The plateau stage is actually the like most controversial. Then you have an orgasm, and then resolution is sort of where you come down from that. And one of the things that was shocking at the time, it kind of cracks me up now, but like they were doing this in the 60s and 70s, but was that men and women were similar in response. So if you think about sort of the 50s, 60s, this idea of like the repressed conservative housewife, right? To realize that men and women were going through similar things physically and mentally, was shocking. And what they found is that women often responded more slowly, but they could remain aroused longer. They also discovered that some women could be multiply orgasmic. One of their other big findings is that the size of your genitals is unrelated to any aspect of sexual performance. Bigger isn't better, right? Alrighty. So our activity today is something that you're gonna do just for yourself, one-on-one. So I'll open it and then I'll bounce back here. It'll have you make a copy of the document when you follow this tiny URL. It's doing very slowly. So you can just type this into your phone or your computer. So it's tinyurl.com/102motivates. And it's gonna ask you a series of questions about your own motivation. You're not going to turn this in. This is for you. I recommend keeping a copy for yourself to think about what does motivate you, what keeps you interested, what keeps you focused, and what can help you do well for the rest of the semester in this course. And so you can take your time doing this. We have about 10 minutes left in class. So I'm going to give you all the whole 10 minutes. If you finish it early, you can head out. But just really encouraging you to take this time for yourself and use this as something that might be helpful and motivating to you. And I'll give you points for this based on your presence in class today, so you don't have to turn it in. It's still one solution. Of course it is. Yeah, the internet is slow in this building sometimes. I don't think that the cinder block walls help, right? So yeah, just give it a minute. It even took a minute to pull it up here for me. No, that's a good question. So like if it's not pulling up for you here, you can go and finish it someplace else. That's fine. Oh, you finished it already? Yeah, so if you finish it, you can leave it. But take as much or as little time as you need to do this for yourself, and then, like I said, maybe email it to yourself or save it someplace for yourself so you can refer to it on those late nights when you're studying and you're like, why the heck am I doing this? And I will be across the hall. I'll be entering grades. So if you need me, you can just stop by my office, which is right next to the door out. And I'm gonna shut off the Zoom here. Yeah, that's totally fine.